We had some discussion about a BTK inhibitor plus CD20 antibody. I wonder, Susan, if we talk about venetoclax and BCL2 directed therapy, what are your thoughts? Is it different than this discussion we had previously with BTK plus CD20 antibody? Is there synergy? Do we need a CD20 antibody?
I do think there's a difference, and to be fair, the ibrutinib data, which does not show any difference, is clearly rituximab. So I guess the jury is still out on whether obinutuzumab would make ibrutinib better. And certainly we, as I mentioned from the Illuminate trial, that CR rate of 40% is much higher than you can get with ibrutinib alone and higher than rituximab ibrutinib. So I think the jury's still a little bit out on the whether obinutuzumab adds anything to ibrutinib. Certainly we know from 2 trials now rituximab does not, other than getting a more rapid response. Because of course when you add in the antibody, you abrogate the lymphocytosis, you get to your PR much more quickly. But we now have 2 trials, randomized trials of ibrutinib plus or minus rituximab, clearly showing that the progression-free survival curves are exactly the same. I think in stark contrast to that is the venetoclax data, where we saw in the original phase 1 that the MRD negativity rates were about 20%, and then in the phase 2 relapse trial in combination with rituximab, the trial that led to that combination being the combination used in Murano, the phase 2 rituximab venetoclax had an MRD negativity rate of about 55%. That was recapitulated in the Murano trial. Well, it was about 60%. And we do have very little data with obinutuzumab and venetoclax from the safety lead-in for the CLL14 trial. So the CLL14 trial we haven't heard about yet, but that is the randomized trial of obinutuzumab and chlorambucil versus venetoclax and obinutuzumab. And that before that trial commenced, there was a safety lead-in to give physicians to find out if they could safely give, because this is a much older population, if they could give venetoclax and obinutuzumab safely. So there were about 12 patients there, and 1 patient had a very bad infusion reaction to the obinutuzumab and came off. But of the other 11 patients, something like 10 became MRD negative. So really tiny numbers, but certainly suggesting that there's some kind of synergy going on there. So I think whether you talk about the antibody being rituximab or obinutuzumab, and they may not be the same, there does seem to be a major advantage to adding that to venetoclax, which raises an interesting question on the ibrutinib-venetoclax combination trials that are so many going on now. We touched on them earlier, which is, well, if the antibody adds to one small molecule, but it doesn't add to the other, do you need it with the combination? I don't think we know the answer to that. You know, there are some phase 2 trials that have antibody in there, some phase 2 trials that don't. So perhaps comparing across trials is the way we're going to get a handle on that. But certainly with single agent venetoclax as opposed to being combined with ibrutinib, I think the antibody makes a huge difference.
And we're doing a study, or we're developing a study right now at Anderson that will be a randomized early CD20 antibody with BTK plus BCL2. And the endpoint being to look at MRD and depth of remission with a fixed duration of treatment. So hopefully with that trial we'll be able to get some insight into if there's a benefit to CD20 antibody. I think there is. I think the depth, there's potential there. Particularly I think where we're moving is taking fixed duration and treatment and giving that to patients, and progress will be in terms of depth and increasing the depth of remission with the combinations that we're giving and shortening down the treatment time. So I'm interested in regimens that will get patients where they need to be as quick as possible, that hopefully will reduce cost. And
although there was some data presented at ASH about the timing of antibodies suggesting that it would actually might be better to give it later in the course of the small molecule therapy, and some data to suggest CD20 was upregulated, and hence coming in with the antibody later might be better. And that was very interesting because all of the trials that we have so far, the antibody is front loaded. So
Although that was specific to ibrutinib, right?
Yes.
Not to venetoclax.
Not to
So we don't know
venetoclax.
yet for venetoclax. Yeah.
Correct.
that was ibrutinib. It was Andy Rostrom, I
Right.
think. Ibrutinib and obinutuzumab was added after patients had been on ibrutinib-based therapy.